Good afternoon, everyone, and welcome to session one of the American Liver Foundation's Liver Health Echo program. Today's focus is MASLD 101 and a program overview, and we're thrilled to have you join us today. I'd like to begin with a warm welcome to all of our participants. We are excited to kick off this session, and we look forward to your engagement. Please state your name and the organizations you represent in the chat. We are honored to have two distinguished speakers with us today, and our first speaker today is Dr. Anita Krishnarao. She is a transplant hepatologist at UMass Medical Center. She earned her medical degree from Brown University and her MPH from Columbia University. She completed her internal medicine residency at Tufts Medical Center and her GI transplant hepatology fellowships at Lahey Medical Center. Since 2020, she has served on the faculty at UMass and is currently the Associate Program Director of the GI Fellowship. Her clinical interests include MASH and liver transplantations. If you have any questions during the session, please feel free to drop them in the chat or raise your hand, and we'll address them throughout and during the Q&A after both of our speakers have spoken today. Anita, take it away.
All right. Great. Thank you guys for having me. Let me just share my screen. All right, does that look okay?
Looks good.
All right, great. So thank you again to the American Liver Foundation for having me. I'm excited to talk to you guys about MASH and MASLD. So this should ideally be a brief review of what we colloquially call fatty liver disease. All right, so just to get everybody on the same page, so what are we calling this disease now? So previously this was called NAFLD and NASH. So NAFLD was non-alcoholic fatty liver disease and NASH was non-alcoholic steatohepatitis. And then there was an entity called NASH-ASH, which was a combination of NASH and alcohol-related steatohepatitis. But the updated terms, which were updated a little over, I believe, a year ago for various reasons, including stigma associated with the prior terminology and just sort of lack of, a clear representation of what this disease was, the terms are now MASLD and MASH. So MASLD is metabolic dysfunction associated steatotic liver disease, MASLD, and MASH is metabolic dysfunction associated steatohepatitis. So I'll be using these updated terms wherever possible. And then when you have a combination of MASLD and some degree of alcohol use, now that's called MET-ALD, which is, again, metabolic syndrome combined with alcohol-related liver disease. All right, so what is MASLD? So I like to think about this disease as having three primary criteria. The first is having an increased amount of fat in the liver, hepatic steatosis, and that can be either seen on biopsy or imaging. The second is this underlying presence of cardiometabolic risk factors, which we'll review. And then the third is making sure really there's no other causes for fat in the liver or steatotic liver disease. So when I talk about increased fat in the liver or steatosis, a pathologic amount of fat in the liver is really over 5% of fat in liver tissue. And so this is called, if you don't have associated inflammation, this is called MASL, or metabolic dysfunction associated steatotic liver. And you really, if there's no associated hepatocellular injury, and it's just increased fat in the liver, these are patients who have a decreased risk of going on to develop more advanced forms of liver disease. When you have increased fat in the liver plus increased inflammation, and potentially some degree of fibrosis, those are patients who are more at risk of developing more advanced forms of liver disease and cirrhosis. And really the gold standard way of differentiating between simple steatosis in the liver and steatohepatitis or MASH is with liver biopsy, but as I'll chat about a little later, there's other ways to help assess this. And when you do a liver biopsy, the difference is the presence of inflammation and potentially fibrosis. So in the column on the left at low and high power fields, you see these sort of fat droplets in the liver, and that's what you see when there's increased steatosis or fat in the liver. And on the right side, that's what we call MASH or steatohepatitis, not only do you have these fat droplets scattered throughout the liver, but you also have associated inflammatory cells, which the arrows are pointing to in the bottom right picture. So the reason we're all here today is because this is a disease that's growing in prevalence. And so as there's been a rise in the number of people with diabetes and obesity and other cardiometabolic risk factors, we've seen this massive growth in prevalence of MASLD. And so it's estimated worldwide that anywhere from 25 to 40% of people have some degree of increased fat in the liver. And in areas where that's not, where the estimates are lower, it's thought that maybe we just don't have enough data. So these are people who have increased fat in the liver and may not have associated inflammation or scarring in the liver as a result of this. But there was a study published that was basically a review of all comers with MASLD or just increased fat in the liver. And if you look at specifically people in the US, it's estimated that anywhere from 2.5% to 5% of patients actually have some degree of inflammation associated with increased fat in the liver. And so again, these are the patients who are probably most at risk of developing more advanced forms of liver disease. So part 2 of the diagnosis of MASH and MASLD is having these underlying cardiometabolic risk factors. So the biggest risk factors that are really most associated with MASH and MASLD are diabetes or insulin resistance and obesity, and particularly BMI over 30. Other risk factors are basically other risk factors for other criteria of metabolic syndrome. So as I mentioned, increased BMI, particularly increased abdominal adiposity or increased waist circumference, also hyperlipidemia and hypertension. So certainly if you have a patient who has a concern for increased fat in the liver on imaging or biopsy, and they have these underlying risk factors, then those are kind of the primary things you want to be thinking about when labeling that person as having MASH or MASLD. And the last part of the diagnosis is really ruling out other causes of fat and potentially inflammation in the liver. So not all fat in the liver is fatty liver disease. So it's very important that you get a good history and you make sure that you're evaluating for other forms of chronic liver disease. Because really, most of the liver diseases we think about can cause increased fat in the liver. And again, it's not always related to MASH or MASLD. So the primary one to think about is alcohol use. So making sure you're getting a good history and figuring out, does this patient meet criteria for what we consider clinically significant alcohol consumption, which is listed there. Viral hepatitis is a big one. You also want to think about medications that can cause increased fat in the liver, both macrosteatosis and microsteatosis. And other chronic diseases, including iron overload, copper overload, celiac disease, autoimmune hepatitis, alpha-1 antitrypsin deficiency. All of those things can increase the amount of fat in the liver. Other endocrine disorders, certainly thyroid disease and PCOS. There's also an association of TPN and malnutrition with increased fat in the liver. And the last group I list is patients who have underlying genetic issues related to that can cause increased fat in the liver. And so that's certainly something you want to think about if you have a patient that has increased fat in the liver but doesn't have the typical risk factors for MASH or MASLD, so they don't have that cardiometabolic profile. Certainly want to think about referring to genetics or doing some of this genetic testing, but that's, again, rare scenario. So patients with MASH and MASLD can have somewhat of a variable presentation. Certainly in earlier stages of the disease, patients can be asymptomatic, and that's probably the most common scenario for patients, especially if they don't have advanced fibrosis. Patients can have sort of right upper quadrant pressure as a result of hepatomegaly. And then again, if they have more advanced forms of liver disease, you see probably more of the typical features that we think about with cirrhosis. In terms of lab parameters, patients can have totally normal liver tests and still have fat and inflammation in the liver. So as much as we think about liver test elevation as being like a surrogate marker for underlying inflammation, it may not always tell the whole story. Most common, I would say, is probably this mild AST and ALT elevation. And then you can also see, a mild ferritin elevation on blood work as well. And then it is possible to see increased fat in the liver on really any imaging modality. So there's increased echogenicity on ultrasound, there's decreased hepatic attenuation on CAT scan, and there's increased fat signal on MRI. So if they're getting imaging for really any other etiology of the in the abdomen, and you're concerned about MASH MASLD, it probably makes sense to take a look at the liver tissue and see what the read says, because a lot of times patients come to us in hepatology because of an incidental diagnosis of increased fat in the liver on imaging that they had done for other reasons. All right, so how does this disease progress? So it is variable for different patients, how, what their course will look like. And so about, as I mentioned, 15 to 40% of the population may have increased fat in the liver or steatosis. And that is, a relatively benign stage. Patients typically don't have a lot of symptoms, and the risk of having simple steatosis in the liver is relatively lower. But, as patients develop more inflammation, that's when you start defining their disease as, steatohepatitis, and that's what we call MASH. And so that's a smaller percentage of the population. So that's anywhere from 5 to 10% potentially have inflammation with steatosis in their liver. And so the issue is that we don't always know who's going to progress to MASH, and also who within that category of MASH, who's going to progress to develop more advanced forms of liver disease. But the biggest risk factor of developing scar tissue and more advanced forms of liver disease, including cirrhosis, is really having MASH. So that's that's really the triage that I'll focus on a little bit later, is helping figure out who those patients are. So obviously, once you develop more advanced forms of liver disease, including cirrhosis, there's an increased risk of hepatocellular carcinoma, or HCC. And also, there's an independent risk of developing HCC, even if you don't have advanced fibrosis or cirrhosis. And right now, there's not clear guidelines on who we should be screening for HCC if you just have MASH. But I will say, certainly if a patient has more advanced fibrosis on workup, then HCC should definitely be on your radar for something to screen for. All right, so how do we triage these patients? So obviously, if 40% of the population has some degree of MASLD, then obviously we can't be seeing all of these patients all the time. So how do we figure out who the higher risk patients are? So the AGA, the American GI Association, put out this clinical care pathway, I believe a few years ago, to really help kind of providers in the primary care setting risk stratify patients with MASLD. So the initial triaging is performed by non-invasive testing, which is we call NITs, and that's the scoring system that's been very well validated is called a FIB-4. So the FIB-4 is that initial branch point there, and the FIB-4 is really a calculation based on 4 variables: a patient's age, AST, their ALT, and the platelet count. So if you're considering a diagnosis of MASLD, or you've already diagnosed someone with MASLD, you want to make sure that you're calculating this FIB-4, because this will help you determine their risk of having advanced fibrosis. So if the FIB-4 calculation is less than 1.3, then their risk of having advanced fibrosis is relatively low. If that score is above 2.6 or 2.67, and I have these cut points on a later slide, there's a much higher risk of that patient having advanced fibrosis. So this scoring system is not, the FIB-4 is certainly not perfect. And for patients who are over 65 years of age, it's been thought of as being less accurate. And so the cutoff for having advanced fibrosis is actually less than 2. So if you have a patient who's over than 65, and their FIB-4 score is less than 2, again, the likelihood that they have advanced fibrosis is relatively low. And so there's a bunch of these similar non-invasive tests, as I mentioned, they're called NITs, that are based on blood work parameters. And so the strength of these tests is their ability to exclude advanced fibrosis. So these aren't great tests to tell you if someone has moderate fibrosis, but they're good in the sense they can rule out advanced fibrosis. And as I mentioned, again, with the FIB4 particularly, you have to think about the patient's age and what the cutoffs for advanced fibrosis should be. So if we go back to this clinical care pathway, the next step, once you've calculated a FIB4, if the FIB4 is low, less than 1.3, then that's probably a patient that can remain in the primary care setting with ongoing monitoring of the FIB4 and other, liver-related parameters. If their FIB4 is in that sort of moderate risk range or certainly above 2.6, those are patients that you want to do additional testing. So while the AGA put out that clinical care pathway in 2021, there was an updated clinical care pathway put forth by Ranella et al. In 2023 that really recommended layering these non-invasive tests. So while an individual non-invasive test like the FIB4 is great for that initial triaging, I think the strength lies when you can layer these non-invasive tests to really get a more accurate assessment and assess the risk for your patient to have more advanced forms of liver disease. So the non-invasive test that this updated clinical care pathway suggests is the BCTE, or basically elastography, which I'll talk about, or the ELF test. So that's here. So and that's for patients, again, if they have a FIB4 that's over 1.3, it's important to consider maybe doing some of these other non-invasive tests to help corroborate that assessment. So the ELF test is, the ELF stands for Enhanced Liver Fibrosis, and it's basically a blood test that measures three markers of fibrosis in the blood. They're listed there. And so the lower the score, the less likely the patient has fibrosis, and the higher the score, the higher likelihood of advanced fibrosis. And it has a pretty high diagnostic accuracy for assessing the presence of liver fibrosis. Elastography is another method. It's not a blood test, but it's a test that some of us have access to, and there's a couple different ways to perform elastography. But it's basically measuring liver stiffness as a marker for how much scar tissue is in the liver. So the most common form of elastography is this vibration. One of the more common ways to perform elastography is vibration-controlled transient elastography, or VCTE. And it's basically where you take a probe and it emits these vibrations to the liver, and based on the density of the liver tissue gives you a score, and that score is reflective of how much scar tissue is potentially in the liver. There are some sources of variability for these measurements. So if there's a lot of inflammation, potentially alcohol use or other etiologies in the liver, that can throw off your readings. If there's congestion in the liver from potential cardiac disease, that can potentially be a source of inaccurate measurements. If the patient has increased abdominal adiposity and there's a greater distance between the probe and the liver tissue, that again could impact your measurements. And then certainly if they have ascites, anything that impacts the distance from the probe to the liver tissue, it will impact your assessment. But if you have if you're able to get accurate numbers based on elastography or the VCTE, you'll get two readings. You'll get a CAP score, which is a measurement of how much fat is in the liver tissue, and you'll get a KPA score, which is reflective of how dense the liver is and how much scar tissue is in the liver. And based on the underlying etiology of liver disease, there's different cut points to help you stage fibrosis in your particular patient. So with a score of a 7 or below, the patient really is suggested to not have really significant fibrosis. And then as you can see, as the KPA scores increase, that leads you to think about more advanced forms of fibrosis. And we say anywhere around 15, KPA of 15 or higher, you're looking at more advanced fibrosis for that particular patient. The other primary form of elastography that we use is MR elastography. So this is a good choice, especially if the VCTE is not giving you accurate readings, or your measurements are sort of not consistent. MR elastography is a nice option if you have access to it, and it's basically doing the same thing based on liver density. It can give you a sense of how much steatosis and fibrosis is in the liver, and the cut points are different between different modalities for elastography. But again, it's pretty straightforward, and most of the times they'll give you the interpretation with this test. So going back to this, this clinical care pathway, if you've layered these non-invasive tests to help figure out, does my patient have advanced fibrosis or not, which again is the kind of major risk factor for complications related to liver disease. If all of those non-invasive tests are low risk, so for example, you do the FIB4 and the ELF test and some form of elastography, if all of your measurements are low, then that patient probably has a low risk of having advanced fibrosis, and they can, again, potentially stay in the primary care setting with ongoing monitoring of their liver disease and ongoing monitoring of these non-invasive tests, potentially on an annual basis. If there's concern for maybe intermediate, moderate risk, because any of these tests are, fall into this intermediate category, the ELF test is, falls between somewhere in 7 and 10, and the elastography is giving you this mid-range result, which is consistent with maybe having some moderate fibrosis. Those are patients that probably should be monitored more frequently, at least on an annual basis. And if there's tests that are discordant, like one test is telling you they have a high risk of advanced fibrosis and the other test is telling you that they don't, then those are patients that are appropriate for referral for subspecialist care, GI or hepatology, and those are patients that potentially would warrant liver biopsy, especially if it's going to change management. So I like this graph because it really helps you, again, risk stratify your patients with non-invasive testing so that you are referring the patients for more for subspecialist care for more advanced or more invasive testing only if these non-invasive tests are suggesting that there's more advanced liver disease present. I wanted to switch gears. So the second part of my talk is just a review of the management of MASH and MASLD. So once you have that diagnosis and you've risk stratified your patient, then what do you do? What do you do for them? So obviously this is a very, this topic is large and it's complex, and patients with MASLD have a lot of times multiple underlying cardiometabolic risk factors. And so care should really be multidisciplinary. And I think there is a talk later in this series that's going to focus on that. But this is just to highlight that multiple providers are often necessary to provide comprehensive care to these patients. But the cornerstone of management for patients with MASH or MASLD and certainly who have obesity is really weight loss. And so the recommendation for patients who have an elevated BMI and obesity is to target at least a 5 to 10% total body weight loss. And so we know based on prior studies that based on prior serial biopsies that were done during prior studies, that if a patient loses over 5% of their body weight, they potentially will see an improvement in the amount of fat in the liver. If they lose over 7% of their total body weight, you can see an improvement of fat and inflammation in the liver. And if you lose over 10% of your total body weight, you can see improvements of fibrosis in the liver. So this is important, and this has been demonstrated across the board in really with any form of weight loss. And so in terms of specific dietary recommendations to make to your patients, which is always a common question. So the biggest thing is really to avoid alcohol, particularly if patients have any degree of fibrosis in their liver. Two liver diseases is certainly worse than one, so avoid alcohol if possible. There's been studies on various types of diets. There was a prospective study looking at the Mediterranean diet versus a low-fat diet, which are two of the more commonly recommended diets. And both actually had similar impacts to patients with MASH and MASLD. But the Mediterranean diet was a diet that was felt to be easier to adhere to in the long term. We typically recommend that patients avoid highly processed foods, particularly high fructose diets. These diets have been implicated in the development of obesity, and which is obviously a big risk factor for MASH. And these diets have been linked to like increased fat in the liver, increased insulin resistance and inflammation in the liver. And then I also do say if patients enjoy drinking black coffee, that it continue to do so. So drinking black coffee 2 to 3 cups a day has actually been negatively correlated with the development of MASH and MASLD and fibrosis in the liver. And in review studies, it's actually been associated with reduced death from chronic liver disease and reduced risk of HCC. So why that is, I don't think we know definitively, but something to mention to patients if they're curious about what they should be following. In terms of exercise, the recommendation is really 150 minutes per week for the patients who are able to do that. And that should include some degree of strength training as well, 2 to 3 times a week. And then high intensity interval training is particularly effective for reducing visceral adipose tissue, which is a driver of insulin resistance. So again, if a patient's able to exercise on a regular basis and looking specifically for what sort of exercises to do, the high intensity interval training is beneficial. And as we all know, there's certainly benefits of regular exercise outside of weight loss from a cardiometabolic health perspective. All right, and so the last part of this, I just wanted to focus on some of the medical therapies that we now have available to us for patients with MASH and MASLD. So for the longest time, for over a decade, we really didn't have much. And now, as I'll mention, new medications are coming out for this disease. But this was the PIVOT study that was published in 2010, looking at vitamin E and pioglitazone in patients with MASH. And so patients with biopsy-proven non-diabetic MASH were given vitamin E for, I believe it was 96 weeks, and there was improvement of features of MASH on biopsy at the end of the trial, but there was no improvement of scar tissue in the liver. And pioglitazone similarly was looked at in patients with biopsy-proven MASH that didn't have cirrhosis but did have diabetes, and again similarly demonstrated improvement of MASH on biopsy, but again was not associated with improvement of fibrosis at the end of the trial period. But this is ultimately what we had for a period of 10 years or greater. There's now this next wave of medications that's coming down the pipeline. One of them already approved, FDA approved. But I show this slide just to demonstrate sort of the complex pathogenesis of MASH and all the different therapeutic targets that are being studied as potential in drug development. So the first one I want to talk about is resmetirom. So this is the first medication that's been FDA approved in this next wave of medications. It's a thyroid hormone receptor beta agonist. And these receptors are primarily expressed in the liver. And so this is an oral daily pill, and they saw in the phase 3 study that at about a year, patients on this therapy had improvement and actually resolution of MASH on biopsy. And about 30% of patients had improvement in scar tissue on repeat biopsy. And so based on this analysis, they received accelerated FDA approval. And so we now have this medication to use in patients who have MASH with moderate to advanced fibrosis. And to use this medication, patients don't require a biopsy, but again, they can satisfy this criteria using elastography or non-invasive testing. And as I mentioned, it's a daily pill, it's weight-based dosing, and there's really no contraindications to use. So this is why it's particularly important to get a sense of how much fibrosis a patient has if they do have MASH, because now this medication may be an option for them. All right, so there are some drug-drug interactions to be aware of. There are some statin reductions that need to happen if you're putting a patient on this medication. As I mentioned, it's a thyroid hormone beta receptor agonist, and even though it works on the beta thyroid hormone receptors, it's appropriate for use for patients who have stable thyroid disease. This is not a medication that's recommended or approved for patients with cirrhosis, however. It's really for patients who have moderate to advanced fibrosis. But there are ongoing trials looking at this medication in patients with well-compensated cirrhosis, so more to come. So going back to other pathways that may be therapeutic targets and have been shown to be therapeutic targets for patients with MASH are the GLP therapies. So GLP-1 based therapies are are feverishly being studied for this disease, obviously because it's a disease that responds to weight loss, and GLP-1 based therapies are very effective at leading to weight loss. So there's a variety of GLP-1 based therapies that are being evaluated, but the one that's actually now being submitted for FDA approval is semaglutide, which we know well in the endocrinology world. So semaglutide, which is just purely a GLP-1 agonist, was studied in patients similarly with MASH who have some degree of fibrosis. And after 72 weeks, again, semaglutide was demonstrated to improve MASH on biopsy, so inflammation and fat in the liver on biopsy. When we look at the trial data, a lot of this improvement correlated with total body weight loss. So as we would expect, a medication that leads to weight loss is also good for the liver in patients with MASH. So, and the interim analysis actually suggested even more favorable results. So MASH resolution on biopsy occurred in about 60% of patients compared to 30% of patients on placebo. And there was also an improvement of fibrosis in up to 37% of patients at the end of this trial. So semaglutide may be approved in the near future as another therapeutic option for patients with MASH. All right, and then I just wanted to mention a couple others. There's other GLP-1 based therapies, including survodutide, that also showed benefit in patients with MASH at 48 weeks, and tirzepatide, as a medication we're also familiar with in the endocrinology space, which is a GLP-1 and GIP, also demonstrated benefit in MASH at the end of their 52-week trial, and also demonstrated improvement in fibrosis. Although that was not statistically significant. So again, just to mention other drugs that are being studied and may be coming down the pipeline for MASH in the near future. And outside the GLP-1s, there's also a couple other medications that are actually in phase 3 studies as well. So just, again, wanted to mention that in other medications are probably nearing potential approval based on the data thus far. And I think the goal is in the future that we have this arsenal of medications that we can choose from based on the patient profile, the patient tolerance, what's covered by insurance. And so ideally, we'll have a variety of medications to choose from. But for right now, resmetirom is the more liver-directed therapy. It's not targeting weight loss, but targeting increased fat metabolism in the liver. And that medication is FDA approved for MASH with fibrosis. And combining that medication with other weight loss medications, including the GLP-1s, is kind of the medical strategy we have at this point. And then just a brief mention of bariatric interventions, because again, if the cornerstone of management for patients with MASH is weight loss, bariatric interventions are certainly effective for weight loss. And so without going into the data here, just to mention that there have been prior studies, observational studies that have looked at patients with MASH who've undergone bariatric surgery, and more recently, patients with MASH who've undergone endobariatric surgery that have demonstrated improvement in MASH in the sense that they've had reduced fat and inflammation on follow-up biopsy after achieving weight loss with these interventions. So certainly something to consider for patients who are surgical candidates or endobariatric candidates. So just a quick summary, and sorry, I think I went a little over time, so I apologize, but just a few takeaway points is that the diagnosis of MASLD really requires thinking about 3 criteria: the increased amount of fat in the liver, the presence of underlying cardiometabolic risk factors, and performing the remainder of the chronic liver disease workup, because not all fat in the liver is MASH or MASLD. In order to risk stratify these patients, it's important to utilize these non-invasive testing strategies to help determine which patients would really benefit from further subspecialist care and medical management. Lifestyle modification is the cornerstone of therapy for patients with MASH, and certainly intensification of risk factor management, including diabetes and obesity, are very effective strategies. And certainly it's important to consider medical therapy with resmetirom or GLP-1 based therapies to achieve weight loss, potentially even bariatric surgery or endoscopy if the patient has class 3 obesity, because again, weight loss is a very effective management strategy for the patients who have underlying obesity as well. So that's all I have. That was the whirlwind tour of MASH and MASLD, and I'll transition over to Dr. Buckholz. Thank you.
Thank you, Dr. Krishnarao. So our next speaker today, he'll be doing a case study for us, is Dr. Adam Buckholz. He is a hepatologist and clinical researcher at Weill Cornell Medical College. He practices in their multidisciplinary metabolic liver disease center, the Innovative Center for Health and Nutrition and Gastroenterology, or iChange for short. His research spans wearable technology, predictive modeling, and MASLD MASH, supported by an NIH KL2 Career Development Award. And you can go ahead and start sharing, Adam, when you're ready.
Okay, well, that's coming through okay. So after that great talk, we want to consolidate this a little bit by going through some cases here. And the goals for these is to appropriately diagnose MASLD and discriminate it from other common liver diseases, to then risk stratify those patients and figure out who needs to be referred to a hepatologist for additional management, and then to appropriately treat those with both low and high risk disease with the dual goal of reducing liver and cardiovascular mortality, because as discussed, one of the main outcomes of patients with this condition is cardiovascular disease as well. And keeping in mind sort of our criteria here, that we want to really start with this metabolic syndrome, which is defined by these criteria: high weight, insulin resistance, high blood pressure, and then lipid abnormalities. So this is Miss Metabolic. I promise it's not going to get any better in terms of these names from here, so just buckle in. But this is a 52-year-old lady. She is coming in for routine health evaluation. She's pre-diabetic. She's got some high cholesterol, depression, some family history of metabolic disease, and she's just treated with metformin and venlafaxine for her mood. Vitals are notable for an elevated BMI. She has class 1 obesity, slightly elevated, but not out of control blood pressure. And then she does have some elevated lab tests from her liver that were similar the year before: mildly elevated LDL, HDL that's sort of low normal, and elevated triglycerides. A1C is in the pre-diabetic range, and platelets are normal. So what would we do next? So sort of going off of what Dr. Krishnarao said, we want to first figure out, why are these liver tests elevated? Certainly we want to consider MASLD, but we want to talk about other things. For example, this particular patient barely ever drinks alcohol when she goes on vacation or if she's at a social event. She doesn't have hepatitis B or hepatitis C. And the other really common thing you need to consider is hemochromatosis. Her iron studies are within normal limits. So we do get an ultrasound, a critical part of the diagnostic steps. She has increased echogenicity, which is kind of the buzzword on ultrasound for fat in the liver. Liver's a little bit big. Normal is about 15. We don't go crazy when the liver's slightly enlarged, but often seen with hepatic steatosis. Nothing scary like a mass or nodularity. So we know that she has steatotic liver disease, which is this big bucket that we're starting with here, and that's based on consistent imaging. So we start with steatotic liver disease. Do they have cardiometabolic criteria? In this case, yes. So, and there are no known other causes of steatosis, like, for example, alcohol use or classic medications. So this person does have MASLD. So how do we decide what needs to happen with them next? The next step is to do some good risk stratification. And as Dr. Krishnarao mentioned, the workhorse here in the primary care setting in most cases is a FIB4. And we can do her FIB4. There's no reason to memorize this. There are plenty of calculators online. Often Epic or other EMRs will embed a calculator in there for you. This particular person is low risk, and truly you can stop there in terms of diagnosis. It's not inappropriate to have this person get a transient elastography, but it's not considered necessary. So it depends on your resource environment, the ease with which you can get transient elastography or fibroscan, but I don't think you need to, in this particular patient, feel strongly that it has to happen. Certainly, they should not be getting MRIs or biopsies at this time. So the management of this patient, the primary goal is to improve their cardiometabolic status through weight loss. And in this case, because they do not likely have fibrosis, we can target sort of more moderate weight loss goals. Dr. Krishnarao mentioned the 5, 7, and 10%, which are sort of easy thresholds. So in this case, we would target 5 to 7% total body weight loss. And that would be through nutrition evaluation, and increasing exercise, and then could discuss a weight loss therapy if persistent obesity. And then it's important to do cardiovascular risk modification, because for people without fibrosis, by far and away, the more likely thing to cause them morbidity and mortality is heart disease. So considering a statin for this patient. And then one thing that's often forgotten is to screen for sleep apnea in people, because that can actually worsen long-term outcomes for all of these. And then in a year or two, she should repeat one of these non-invasive tests, for example, a FIB-4. So this is Miss Ina Sue Lin for case number 2. So this is a little bit different. So she has diabetes. She's had diabetes for the last 8 years. She also has high cholesterol. She's been diagnosed with sleep apnea and has some cardiovascular disease, some AFib. Again, some family history of metabolic disease and some bad outcomes related to that. She's being treated with Januvia, metformin. She's on Eliquis, and she's on a statin, a low dose of Crestor. She is also obese. Blood pressure is a little bit higher in this case. Heart rate's well controlled. She also has elevated liver tests, similar to our last patient, although if you notice, in this case, the AST is a bit higher than the ALT. Often when we see AST higher than ALT, the sort of classic is to think about alcohol, but additionally, you could think about fibrosis. In fibrosis, the AST tends to be a little bit higher, and that's reflected in the FIB-4 score. This person also has bad cholesterol. Their HDL is a bit low, and their diabetes is not as well controlled as the other person who only had pre-diabetes. So what should we do next? Again, we're going to start in the same place. We ask about alternative causes of liver disease. This person has a little bit more alcohol, weekly alcohol use, but again, usually in the 2 to 4 drinks a week range. And they do not have hepatitis B or C. Same exact labs for the iron, does not have hemochromatosis. In this case, we also see the same thing, slight hepatomegaly, increased echogenicity. But we need to go a little bit further because this person has steatotic liver disease, same as the next one, or same as the previous one. But Miss Ina Sue, when you do her FIB-4, she is in the intermediate indeterminate range for the FIB-4, 1.91. So Dr. Krishnarao talked in more depth than I'm going to about sort of these screening test options. So you could go to an ELF test here, but if available, I would move to a fibroscan or transient elastography. It should also be noted that in diabetics, FIB-4 might be a little bit less accurate. So there are a lot of recommendations that suggest that in diabetics, because the rate of fatty liver and the risk of progression of fatty liver is much higher than in non-diabetics, at least a one-time fibroscan should be offered almost regardless of their underlying history. And really the reason is because we're trying to bucket out these patients. So there's a whole ton of people who have steatotic liver disease, about 35% of Americans. Most of those are going to be MASLD, with a smaller proportion being alcohol related. But you really, as we go along, there's much smaller buckets of people with more advanced disease. And we really want to identify those people with fibrosis and cirrhosis, because we're seeing incredible increase in these numbers of patients as time goes on and as the metabolic syndrome epidemic continues in the United States. So in order to bucket this patient correctly, we want to do ideally a fibroscan test. And this is what the results look like if you've had patients that have gotten them. On the left, you see somebody who's very, very low risk. They are somebody without fibrosis at all. And then in the middle, between a KPA of 8 and 12, these are moderate risk patients. And They should be considered for hepatology referral. They maybe would need confirmation with another test, but there's concern that they have some fibrosis. And then on the right-hand side are patients with more extreme levels of fibrosis that always should be referred and probably will need intensive intervention. So in this case, we have somebody who's in that middle bucket. Their KPA is 10.8, and they do have significant steatosis on their fibroscan. So they should be referred for hepatology. The hepatologist may decide to do an MR elastography to sort of confirm concordance, but not always necessary. In this case, they need aggressive lifestyle changes. We'd be talking about a 10% reduction in body weight. So they should see a dietitian if that's available. Exercise, they should use their CPAP. It'll help with weight loss. Anybody who has significant fibrosis, we tell do not drink any alcohol until your fibrosis has resolved. So even the small amounts of alcohol are potentially damaging in this patient. So additionally, they can be considered for GLP therapy. They are diabetic and obese. You could consider bariatric surgery, again, with the goal of losing about 10% of body weight. You would increase their statin dose as they tolerate it. And if their triglycerides stay high, you could even consider fibrates or fish oil to try to reduce triglycerides. So this is for cardiovascular risk modification, but really the first line therapy for patients with high risk MASH with fibrosis is resmetirom, as Dr. Krishnarao mentioned. We also have a number of clinical trials that are currently ongoing. And the only thing to note here is that resmetirom, because of a potential drug-drug interaction, there is a maximum dose of statin that you can take with resmetirom. So just to be noted in this case, largely it's a very, very safe, well-tolerated drug. And so I would not hesitate to use it in this patient, especially once you've maximized their benefit from the other lifestyle interventions. And then in patients with advanced fibrosis from MASLD, there is some consideration whether or not they should be getting hepatocellular carcinoma or HCC screening with an ultrasound and an alpha fetoprotein every 6 to 12 months. There's some controversy as to the cost benefit of that, but something to consider in patients who do have significant fibrosis. And then Mr. Cyril Osis will be our last case. He's a 63-year-old guy. He's coming in for worsening fatigue. He's had a long-standing history of diabetes, hyperlipidemia, sleep apnea, and AFib, same like the last patient. Again, some family history of metabolic disease and bad outcomes related to metabolic disease. He's on same medications as our last patient was. He's also obese. Blood pressure is a little bit better controlled in his case, or at least lower. And you'll see that his lab tests are additionally elevated in this kind of mild to moderate range with an AST predominance. Cholesterol is the same as our last patient. And unlike our last patient, we do see that their bilirubin is slightly elevated and platelet count is slightly low, which are things to potentially be concerning to us. So what would we do next for him? Same idea. So this guy, he says he only drinks alcohol when he watches baseball, but then, it turns out he really loves baseball. And then so when you watch baseball, how much are you drinking? And he says, well, a couple, one or two. And his wife says, Cyril, you have to be honest, it's the doctor here. So it turns out he's actually drinking 3 or 4 drinks about 5 nights a week. And then additional testing, you're seeing that he has increased echogenicity, with potentially a nodular contour to his liver, same larger liver, and the spleen on this ultrasound is slightly large. Does not have hepatitis B or C. The ferritin is slightly elevated, but the iron saturation is normal, which would not raise suspicion for hemochromatosis. As Dr. Krishnarao mentioned, more advanced steatotic liver disease, whether from alcohol or from MASLD, can cause ferritin to rise. So this patient also has steatotic liver disease. We see it on imaging, and he has metabolic risk factors. So this patient does have MASLD, but there also is alcohol use. And so here's our sort of spectrum, the updated way to diagnose this. This condition of MetALD was briefly mentioned in Dr. Krishnarao's presentation. So in a patient that has MASLD, but then also has increased alcohol intake, you want to calculate out how much alcohol they're using. And so this person's averaging about 3.5 drinks a day, 5 days a week. so about 245 grams of alcohol weekly. So that would put them in this met ALD condition. Regardless, we've got this bad looking ultrasound, some sort of scary looking labs. And in this case, I don't think a FIB4 is particularly necessary, but you will note that if you did one in this patient, it would be high risk. It was noted that over age 60, the FIB4 is less accurate. And then also liver tests may paradoxically decrease in cirrhosis as liver tissue dies and becomes less functional. Actually, it'll produce less ALT and AST. So we can't use ALT and AST as accurately in patients with more advanced disease. A transient elastography may help to support or confirm this diagnosis. But most important, there's a clinical picture here concerning for more advanced liver disease, for cirrhosis, and that makes this patient high risk for decompensation and liver cancer or HCC. When they see the hepatologist, they may consider a biopsy. And when we do get biopsies, which is what the fibroscan or the transient elastography is trying to approximate the estimations from biopsies, it gets a little bit squishy. So biopsies and elastography are really good at very low levels, so stage 0, or at very high levels, so stage 4, cirrhosis, where you can, if you see a lot of these, you can see these nodules starting to form within the liver parenchyma. It's a little bit squishy in 1 to 2 to 3, but in this case, somebody may perform a biopsy to confirm this diagnosis of cirrhosis, or could use the lab tests and the imaging findings to say, you likely have more advanced liver disease. So in this case, even though he's obese, you wouldn't want to push quite as aggressive weight loss because there's a higher risk for sarcopenia in patients with more advanced liver disease. You can likely use GLPs in this patient population, but I will say they're less well studied, and you do have to be careful because of the concern for muscle mass loss. And I would engage the help of a dietitian if you have access to it. These people do need to be surveilled for HCC. And there are several clinical trials that are ongoing looking at patients with MASH cirrhosis that is compensated, meaning they haven't had any decompensation events. But there are no FDA pharmacotherapies that are approved for patients with this advanced disease at this time. So in this case, a hepatologist really needs to help manage their cirrhosis and optimize them in case they were to need transplant. So in summary, all patients with metabolic risk factors should be screened for MASLD, but especially those with diabetes and obesity, especially the central obesity, visceral obesity. The diagnosis of MASLD requires considering other causes of liver disease and getting some relevant imaging. Usually that's an ultrasound. You do not need to do the $1 million workup and try to find autoimmune conditions or other problems related to other potential rare liver diseases. Ruling out the more common ones is helpful. And then after you've diagnosed somebody, you feel confident that they likely have MASLD, they need a risk stratification. First line in the community should be FIB4, and then you can use ELF or transient elastography to help with those with indeterminate or higher risk. And then for those with diabetes, you may just want to get a one-time transient elastography or fibroscan. So it's also important that we do appropriate cardiovascular risk modification, the weight loss targets that we talked about. This cardiovascular risk modification is really because in those with MASLD, the leading cause of death is still cardiovascular disease, and the rates of both all-cause and fibrosis and liver disease-related mortality sharply increase once you see fibrosis in a patient. So once you get to stage 2 or higher fibrosis, the risk of all-cause mortality is much higher than the general population, and a lot of that is driven by liver disease. So we want to refer those high-risk patients to hepatology, which would prompt aggressive multidisciplinary care and management, weight loss, risk factor modification, and possibly using resmetirom or consideration of a clinical trial, and then identification and appropriate management of cirrhosis. And that is my talk, so I will stop sharing.
Thank you so much, Dr. Buckholz. That was really good. Let me share my screen here. Do we have any questions for our speakers today? Be shy. No, nobody. Well, if you think of any questions, we'll provide their emails after this as well. If sometimes it might take some time to come up with some questions, but we have a few minutes left, so I got a couple more things to talk about here with y'all, and then we'll get going. So I just want to talk to you guys a little bit about the American Liver Foundation. We are the nation's largest nonprofit dedicated to liver health, and our mission is to educate, support, and advance research. And we have several key programs, and a couple of these include our patient registry, which is a national initiative designed to collect data from individuals 18 and older in the US with any form of liver disease. And its purpose is to help researchers better understand liver diseases, evaluate the effectiveness of current treatments, and improve patient outcomes. All patient data is kept private, so participants remain actively engaged by updating their health status and may be invited to join future research studies. And then also we have Think Liver, Think Life. This is the American Liver Foundation's flagship public health initiative focused on raising awareness of liver diseases such as MASLD and MASH and liver cancer, promoting early detection and better outcomes, and reaching underserved communities through education, screenings, and public campaigns. We also have a wide range of resources from caregiver guides and clinical trial info to nutrition videos and wellness webinars. You can find transplant centers, physicians, and even connect via our helpline or live chat. And I've also included a QR code here for you to scan so you can explore more. And these are our upcoming sessions. Our next one will be on Tuesday, September 2nd, same time, 12 o'clock Eastern. So make sure you scan the QR code to register if you haven't already. And with that, we will also have a special thanks to our program sponsor, 89Bio, for sponsoring the 2025 IECHO sessions. And that being said, this concludes our first session. Like I said, our next session will be on Tuesday, September 2nd, covering MASLD and comorbidities. And before I let everybody go, did anybody have more questions for our speakers today?
There is a question in the chat.
Is there? I can't see it from my screen.
It looks like Blair is asking if there are herbs that can worsen MASLD. And so herbs and supplements are an extremely fraught topic when it comes to liver disease. So I think that there's two sides of this. One is that in general, there is really poor prospective controlled data to suggest whether there are direct hepatotoxic effects of most herbal supplements. There are many that seem to be safe, and while not evaluated in a good prospective manner, are likely things that you don't have to discourage patients from taking. The most sort of common that we hear is silmarin or milk thistle. This is one that's been considered frequently for reducing liver inflammation, so to speak. In general, I discourage all of my patients from taking supplements that have long ingredient lists. So if they're going to take a supplement, it ought to be a single supplement for a single purpose and taken at the recommended dose and after discussion with their doctor. And milk thistle is no exception there. So when people come with immune complex or gut health supplements and they have a list of 30 ingredients, there are a lot of risk for causing what's called an idiosyncratic liver injury. And that may include steatosis because there are a number of drugs that increase steatosis in the liver. Some supplements that are very common that have shown that you will find studies that suggest they're helpful in MASLD, but actually may paradoxically worsen liver health are things like ashwagandha and turmeric or curcumin, which we've had to start discouraging people from taking because there are a lot of reports of liver injury related to them. The other thing that can increase steatosis of the liver is anabolic steroids seem to cause some increase in liver steatosis, and corticosteroids can do that. So if there are supplements that are intended to increase androgens or steroids and then they have steatotic liver disease that you can't explain, I would also discourage them from taking that. Dr. Krishnarao, I don't know if you have anything to add to that, but.
No, I have the same perspective. I mean, I think there's such limited data to suggest that a lot of these supplements that are now on the market, especially the ones that are marketed for liver health, none of these have been studied, as you mentioned, in a prospective way. And certainly if it's one ingredient and it's an appropriate dosing and a patient feels strongly about taking it, and as long as it's not causing harm, and there's not definitive data to suggest it's high risk for drug-induced liver injury, I think it's, everything is risk versus benefit, but there's certainly nothing that I'm a proponent of because I just think the data is not there. But with any supplement, especially the ones that have multiple, like you said, multiple components, I really discourage taking those because even if it's the majority of patients aren't going to have an issue, and we've all certainly seen those rare cases of drug-induced liver injury that, especially if you have underlying liver disease with any degree of fibrosis, it can be a significantly worse outcome. So, nothing additional.
There was another question in the chat there. Treatment protocol for MASLD, I think you meant to say MASLD, for primary care physicians in rural settings.
Yeah, I think, and it's really kind of the review of kind of what we chatted about. I think step one is making sure the patient truly does have MASH or MASLD and going through that protocol and ruling out other risk factors for other liver diseases, particularly alcohol-related liver disease. If they have underlying cardiometabolic syndrome and cardiometabolic risk factors, is really intensifying the treatment regimens for those underlying risk factors, and certainly, promoting weight loss for patients who are, who do have meet criteria for obesity. That's kind of the bulk of what I think the primary care that's the bulk of the role of the primary care, because that part is incredibly important. And all of these drug trials that are coming out, I mean, those are all in conjunction with intensive lifestyle modification. So none of these drugs are being studied in isolation. They're all being studied alongside, intensive counseling for, dietary and exercise, increased dietary and exercise regimens. And then, I think if you've appropriately diagnosed someone with MASH or MASLD and you do these non-invasive tests with the blood, the blood work or elastography, and you have a concern for some degree of fibrosis, that's where the medications come into play. So right now, the only one that's FDA approved is resmetirom. And certainly if there's a role, as and Dr. Buckholz mentioned, for GLP-1s, if there's a role for treating their underlying diabetes or obesity with a GLP-1 based agonist, that's certainly part of the treatment protocol. But I think, sometimes it's, we downplay the importance of sort of all of that basic management and lifestyle modification for patients with MASH MASLD, because that's really going to forever be the cornerstone of management.
Any more questions?
I think the only thing to add to that is don't be scared to send an ELF if transient elastography in the rural setting is difficult, because I actually being in New York City, not generally considered a rural setting, we don't use as much, but it's actually when we have patients that are further out or they're coming further away and we have something, the FibroScan was down that day or something, it's actually very easy. LabCorp and Quest both run the ELF, generally very low, if any, patient costs at all. So don't be discouraged. And I think the other thing is that exercise is a very critical component to this in low risk MASLD, and especially, but all forms of exercise, even regardless of weight loss, seem to reduce risk of progression of disease. And so in the rural setting or sort of the underserved setting, there are a lot of applications now, especially for patients that have access to mobile health type things. Finding a good application that sort of can take some of that burden off of you and can engage patients to try to get that 150 minutes is good. And so it can, doesn't require as much sort of intensive resources, medical, healthcare resources.
Any more questions? All right. Well, thank you all for joining us today, and special thanks to our speakers as well. Our next session will be Tuesday, September 2nd at the same time, 12 o'clock Eastern.